Okay, it looks like we're rolling. Let me share my screen. Okay, well, we'll get started. So if you haven't signed in, the sign up sheet's going around, and you can use the little scan thing there too. You do both. That this app lets us know that you were here, and it gives uh the foundation that writes the grant that lets them know that you guys were utilizing it. And they're like, oh, okay, so we'll keep doing it. But if they're like, oh, well, we see money going out, but we don't see any students utilizing this resource or anything like that, then they're like, oh, well, maybe we don't need to offer tutoring. So that's how that goes. Um, and so here's a really good overview. Like I saw this video, it's like 8 minutes long, and I put it right up top because it was like everything that was in your like all the important stuff I think you need to know, like in about 10 minutes. And I'm like, ooh, like watch it twice. It's yours in the making. I would watch that twice. And just so you can watch it once and then maybe take some notes on it and then watch it a second time. And you can kind of go through, you could write notes in the margins on these, but um, these are some of the key points from that. And I'm like, wow, these are most of the things that I think it's more high yield, if that makes sense. And so there's stuff that you'll learn. Um, Professor Nichols said this in my nursing pathophysiology class, which was the first nursing class I took. And she said, in nursing school, there'll be stuff that you need to know. There'll be stuff that's nice to know, and there's stuff you don't need to know. And so she told us when it came to like the patho textbook, she's like, don't read it because you don't need to know it. It's too deep. That goes into the don't need to know it. She's like, maybe if you're going to be a physician and or a pharmacist or something like that, you need to know something specific about a particular thing. Hang on to it as a resource. Go deeper when you need to, but you don't need that to pass the NCLEX or to pass nursing school. She's like, focus on the handouts that I give you and you'll do just fine. And she said, most of the time when people do poorly, it's because they get too deep and buried into their textbook or things like and she's like, so don't do that because you'll get too much. You don't have enough mental real estate. And I'm like, okay, that's great. Um, so when I see high yield content, I'm like, ooh, this is good stuff. And that book, you guys have that NCLEX Comprehensive by Saunders. That's pretty much high yield stuff. So that's like focus on that. And that's your Cliff Notes guide to nursing school. Um, my wife discovered it like the last semester of her last year. And she's like, I wish I would have known about this before. And she had it because it was a required tool, right? But she didn't go through it as much as she could have. She's like, that would have been so helpful. So you can read that, like if you're going into med surge, like read the chapter before you have the lecture. And it'll give you, even if you don't understand all the content, at least you'll have heard something. You'll be like, what is preeclampsia? I don't know. But you can read about it. You're like, okay, I know preeclampsia has to do something with eclampsia and has to do something with seizures and pregnancy. You're like, okay. And then when you go take do the lecture, then when they fill in all the gaps, you're like, oh, now it really makes sense. And so you've hit it. Now your brain's hit it a couple of times. So it's really helpful. So that's that big, thick um, comprehensive, or you can get it online too. So we'll go focus on antibiotics quick, and then we'll go through some pain meds. And this is our last one together. So antibiotics only treat bacterial infections. So you might see questions in there about somebody who's got a risk of getting a virus. We don't care about that with antibiotics only treat bacterial infections. And so that's a teaching piece. You always want to finish the entire prescription, even if the symptoms are improving. And you will always have questions like this on the NCLEX, like which one of these things needs more education? When the client says, oh, I can stop taking my amoxicillin when my sore throat goes, and you're like, no, you got to finish all 10 days of it. And so, but you'll see that question. So just know that. Some antibiotics can reduce the effectiveness of birth control. Not all of them, but some of them can. Penicillins and rifampin. And one way to think about it, penicillins and rifampin bump the pill because they also have P's in them. And tetracyclines and cephalosporin retarded child care. So there are basically four: penicillins, rifampin, which is used for primarily used for tuberculosis, tetracyclines, and cephalosporins. But the other ones are pretty much okay. But if you see a question that say like, which one of these, unless they're trying to be really specific about a particular class of medications, you're like, that's one of those patient education pieces that you might want to use a barrier method of contraception because some of these can impact the hormones. And that's all that is. So the hormones are going to be a little bit different. So you want to use an additional form of contraception, primarily like a barrier method, because if you're using a hormonal birth control, it might not work as well. That's all. Photosensitivity, fear the sun. So fluoroquinolones, tetracyclines, and sulfa drugs. I was traveling when I was in junior high. We went to Russia and we were in Moscow and at that point it was Leningrad, I think they had changed the name of it. And that was back in the early 90s. And I got gotten like a sore throat and my doctor happened to be on that trip. And he gave me a script for sulfa that he had there. And I didn't know I needed to put sunscreen on. And I fried, like I turned like the color of your shirt just like instantly. And I'm like, okay, so that's a sulfa drug and sulfa drugs cause photosensitivity. That's how I learned that. So on that, you want to wear sunscreen, even on cloudy days, if it's cloudy, sunglasses, hats, etc. Most antibiotics cause GI issues because they attack all the bacteria. That makes sense, right? And so they're attacking the good bacteria in your bowels as well. And so that's going to start messing with things. You get diarrhea, constipation, helping more diarrhea, and other types of things. And so probiotics can help yogurt, things like that. Kefir. And then this is another one you always see question. You always want to get a culture and sensitivity test before you administer antibiotics. And just sort of think about that for a quick moment. And that's like, if I'm going to find out, you do a CNS, a culture and sensitivity, find out why somebody's got something, what it is. But if you give them antibiotics, you're going to mess up the test. And so you want to get the results, get the test. It might take a little while on the results. It might take 24, 48 hours. We'll get there in a second. But like you want to take the test first and get that sent out to the lab before you give the antibiotics. And you'll see questions on that all the time because that's a nursing thing, because the nurse will be the one probably to get the culture and sensitivity, and they'll be the one, say, administering antibiotics. And so you need to know which ones you need to do first. And it's always going to be get the culture and sensitivity tested first. That doesn't mean get the results back. It means just get the test done, get it out to the lab. So couple key terms we'll go through. Bacteriostatic. This is going to be a review from what you guys learned on Friday. So I'm not going to hit it too hard, but just kind of go through it. Bacteriostatic, inhibit the growth of bacteria. So you think of something that's static, like static cling, your clothes are stuck together, right? Or something static, it doesn't move. And so it prevents it from growing. It keeps the levels the same. And so usually what it does is it interrupts something in the DNA or something along those lines. It doesn't kill the bacteria. So it needs to help with the immune system to go in and finish killing it off, but it makes it so it can't reproduce. So that makes sense. It can't send in reinforcement, can't reproduce until your immune system can usually take it out. You also have bactericidal, which kills bacteria. You could think of cytal like homicidal or genocidal or suicidal. It kills something. And so these are better for those who have a weakened immune system because they don't have an immune system to come in and take out the straggling bacteria, even if they can't reproduce. So it's better to have that. So here's a couple examples from your slide that Professor Bayes gave you of some bacteriostatic versus bactericidal. And unless you really want to go diving deep, you don't need to know that, probably for the NCLEX. And it doesn't look like you have to really know that too deep for this exam. I don't know. She's hard to guess sometimes, on what she wants. I wish I could steer you guys a little bit better, like, hey, this will be on your exam. This won't be. I wish I knew. I think I could. I would if I could. I don't know. Yeah. So a culture is a test to determine the type or the culture of bacteria or viruses causing an illness. And you can think about that back in microbiology. You took a culture from from like a specimen, right? To figure out what was growing. You're like, when you swapped a doorknob, you're like, let's culture this. That's exactly what you're doing. You're doing a culture. You know, what's the culture of the bacteria that's growing or virus, if you want to think about it that way. And then the specificity is going to be a list of anti-infectives, antibiotics typically, that can treat an infective organism. So if it's sensitive to it, then it will show that it'll show that on a report. And you can probably look it up if it comes back. It might be in the patient's chart, but the physician will definitely be looking at that to say, okay, oh, this guy's got this kind of illness or this type of infection in as a UTI. So we need to put him on this medication as opposed to that medication. One of the things that they will do, they want to try to do a narrow spectrum if they can. They try to narrow the spectrum. And the reason for doing that is it's more effective and it's a targeted kill and it's less likely to kill the good bacteria. And it's also less likely to cause superbugs, if that makes sense, because we're not killing off everything we're being more specific. And you can think of like an assassin in some ninja movie versus like, I don't know, somebody dropping like carpet bombing a city to try to get one bad guy, right? You know, okay, we're going to do this narrow spectrum. Broad spectrum is also called empirical, and you can think of like empirical observations or empirical data. It's observation, and that's this person's coming in with these symptoms and these signs, and so it looks like it's going to be a UTI. We're going to go ahead and do the culture and specificity because they've got burning when they pee and are a little confused and they're older. Like it's probably a UTI, so we're going to culture it, but it's going to take 24 or 48 hours for stuff to grow back because you got to culture it, right? When you think about micro, put it on the slide, and then you got to grow it out on the petri dish, and then you got to drop those little antibiotic little discs on it to see what kills it, right? That's kind of what they're doing. If you think about it that way, it sort of makes sense. It takes time. And it's probably faster these days. They can probably do DNA sequencing and go, oh, okay, it's exactly this with this subtype, and now we can use that. But I don't know if we're there yet, but soon, right? But so they'll use broad spectrum so that they can take that culture and sensitivity and then immediately start treating that person, which is great for sepsis or something like that, where you want to get something on board because even if it's not as targeted, the person will die without it. So you want to get a handle on that infection. And then once you get those results back, then you can narrow it. So, like, okay, let's scope it down. And you're like, that makes sense. So you can get super infection. That's more common with broad spectrums. And that's the whole reason we're talking about all this is for what we call antibiotic stewardship. And I'll get there in just a second. But think about that term, antibiotic stewardship. So super infections, it's going to be something like a thrush or yeast infection, and thrush is when you get it in your mouth, and that's yeast. And so you treat that for antifungal like nystatin or diflucan or Mycolex, Troche. I've never given that, so I don't know how to pronounce that very well. Nystatin. One of some of these medications can be like it's one class, and it's pretty much just nystatin. As it is, and I don't think it really has a suffix. Don't let statin confuse you because you have the statin medications which are antifungals, so HGOAs and inhibitors. Don't worry about those. It's a different medication, different type of thing. This actually comes from a bacterial mold. They may be related, I don't know, but they're not in terms of process of what they do. But the things to know here is going to be like fluconazole, which is like flucan, or miconazole, or citronamazole, which is notice here, the conazole or mazole, right? So if you see these on your exam, these are going to be antifungals. And I don't really come up with a really good mnemonic for that one. Maybe one of you guys can think of one. And if you do, you can email it out. Hey, conazole. You're like,
They have mnemonic generators.
yeah.
Yeah.
There you go.
If you ever want. Yeah.
Zol, Azol, Azol. Actually, I do have one, and I don't know if I used it, and I might have used it. I think I did. I think I did it here. C. diff. severe, it's gonna be like cramps and colitis and stuff. You keep this here, and I'll close that gap. So that might occur several weeks after the antibiotic is discontinued. And so what that is, that's basically bacteria diarrhea that we gave them because we went in and kicked out, we killed all the good bacteria. And so now just their entire intestines are a mess, the whole like microflora. Does that make sense? And so we can treat it with metronidazole, that's a different azole, flagyl, and that treats C. diff. And the way I think about this one is azole. So you have bacterial diarrhea coming out of your asshole. And so I'm like, all right, so flagyl, clean out your asshole. All right, you'll remember it. And so I don't know, maybe you can think about these two. It's similar if you got conazole and you're like, yeah, okay, so slightly different, but you got like maybe you got a yeast around your a yeast infection around your asshole. I don't know. And colon is Spanish for with. So with yeast around your asshole. I don't know. You probably won't forget that one. Conazole. You're like, that's gross. I won't ever remember that. Vancomycin is treats C. diff. There's not a lot of things to do. So metronidazole. You should know these. I should have like made them right, just so you know. And then this is new fecal macrobiotic transplant, which is basically you take stool from a donor, like basically healthy poop, and you put it in the poop of you basically do a rectal poop transplant. And I worked with back about 15 years ago, I worked with an infectious disease doctor who was starting to pioneer this. And it was kind of interesting because we're like, you're doing what now? Oh, that's interesting. I was on the IRB, the Institutional Review Board that was looking at some of those studies. That was pretty cool. And so like here, now it's standard of practice. You're like, I know that guy. They're like, that's a crappy thing to know about someone. So the thing about C. diff is it can be fatal with young people or the immune compromised. Probiotics can help prevent it or help treat it. And basically what we're going to try to do is get that bacteria back. And so I was on Augmentin a couple of years ago for a sinus infection. And like about halfway through the course, I started just slamming a lot of those good bodies and things like that and probiotics because I wanted to prevent like the bad bacteria from colonizing and try to go, okay, well, what's some good acidophilus or things like that put in. So I mentioned antibiotic stewardship, right? I wanted you guys to return on that. And that's because what that means is we want to protect the antibiotics we use because there's not a lot of them. And because when we use them to treat things inappropriately, we start making antibiotic resistant medication or antibiotic resistant organisms. And so resistant antibiotics are a growing concern. And so you'll be that nurse friend. And this has happening to me now all the time. I'm getting people calling up like, yeah, my A1C was a little high. And the doc says I should be on metformin. What do you think? And I'm like, I think you should listen to your physician, and you probably should exercise a little more, right? Let's go to the gym next time, right? But you'll be that nurse friend. And people start asking you things, or people will have a viral illness like a cold, and they'll come in, they'll want an antibiotic, right? That makes sense. They want to use the strongest agents as the last resort because if we're going in and we're hitting these minor infections with the big guns, then pretty soon our big guns aren't going to be big anymore because those minor infections are just going to be like, oh yeah. Because if you're not going to kill them all, you'll kill most of them, but you'll still be a few life finds a way. And that's the bacteria reproduce, some mutations occur. Eventually, mutant bacteria survive the effects of the drug, and overuse and inappropriate use exacerbates the emergence of antibiotic resistance. So vancomycin is effective against MRSA, but it's one of the only ones that is still effective against MRSA. And so we got to be conscientious of that. And every once in a while, I'll be trolling through Facebook, and I see these people pop up, and you can get your very own emergency antibiotic kit online. It's got things like azithromycin, ciprofloxacin, and doxycycline. All you gotta do is pay $260. And how does that make you feel that you can buy your antibiotics online without a script and without the need to do it. And you're like, well, who do you think's making superbugs? Hmm? I'm like, yeah. So how does that make you feel, right?
Then how does that work when you compare that prescription is a doctor order one?
Well, yeah, it's a doc shop.
Oh, it's a doctor.
Yeah, it's a doc shop. They'll have, I'm sure they have a doctor writing a script for it. Might even be a veterinarian or something like that. Here you go.
Okay.
Yeah,
So overuse of antibiotics can cause the yeast infection and C. diff or
Yeah.
C. diff?
yeah, both. Yeah, it'll kill, like, if you think about like let's think about like a yeast infection in like in the vaginal area. If we can think about that. Um, and so your body has it's got its own, it's a little bit more acidic down there, which helps to, reduce the amount of yeast that's there. But I think it's also, tends to be a lactobacillus colonies that are down there, which also help keep other things like E. coli in check. But when we give antibiotics that kill off the good bacteria like the lactobacillus, it gives the E. coli a chance to grow, which can lead to a UTI or yeast infection as well. Because now you're getting a yeast overpopulation growth, if that makes sense. Because now the only thing that's there to eat the sugars and other types of things are going to be the yeast as opposed to the bacteria and the good bacteria. So we have, like, one of my favorite things in research these days is what's going on in our microbiome, is to think that you're not just you're like a trillion cells, and then there are like 1,000 different organisms that live on your body. Even if you wash yourself every day, there are different types of bacteria. There are like mites and stuff that are like in your eyebrows. It's pretty weird to think about it. You're like, it's kind of gross on one hand, but at the other hand, you're like, 90% of our serotonin, I think it is serotonin, that's made in our gut bacteria. And so if you think about serotonin, is that hormone that makes us happy and leads to depression if it's too low. And you're like, we can potentially modify our gut bacteria and get rid of depression for most people. And you're like, weird. And there are gut bacteria which influence what you eat by sending certain signals to your brain. And you're like, and they're wondering if there's a connection between that and obesity. And people are like, they're like, I want sugar. You're going to give me sugar because it helps me grow. So it sends a signal to your brain that says sugar. And so the person eats, and it's the bacteria in their brain, like kind of weird, isn't it? It's cool. It's really cool. Like, seems like very much sci-fi. You and your bacteria. Right? Kind of cool. Well, we'll quickly go through some of these antibiotic classes. Penicillin. Um, you've probably all been on amoxicillin, more than likely. Uh, Penicillin is mostly just injection these days, but you'll see it in terms of ampicillin, amoxicillin. Sometimes you'll see like amoxicillin and this colate potassium. We need to pronounce that one better, I think. But that's augmentin. And without going into too much detail, amoxicillin is a class of beta lactams which prevent bacterial walls, the bacterial walls from being strong, and so they basically engage in apoptosis. But some bacteria have gotten pretty smart, and they're like, oh yeah, well, we can synthesize that without beta lactam. We can go around it. And so they can do that, and so that's why they added this form of potassium. It's a different kind of potassium, it's just the salt. But which is a medication that prevents that stage from happening. But that's an example of antibiotic resistance. And then this helps make that drug work again, augmentin. So we'll see that more for GI drugs. So it's mostly gram positive. And so sometimes you'll see these drugs that have additives into them. That's why. It's interesting. It was discovered by 1928 by Alexander Fleming. It was first used in 1941, which was during World War II. And penicillin itself is pretty much already just done. It's because antibiotics have developed, microbes have already developed antibiotic resistance to a lot of it. So that's why you see more like amoxicillin these things. You'll see penicillin G, which is an injection, it's slightly different, so it's not yet resistant. But the thing you need to know about penicillins is anaphylaxis. Like I have there I copied and pasted it in here. There's also an insert by itself in your email that I sent out. But it's a list of like what you should know for the NCLEX for signs and symptoms, or like adverse reactions, I should say, more specific adverse reactions. And so I thought that if you're gonna know for penicillins, think anaphylaxis. And so like how would you treat it? It'd be things like, you know, watching the airway, probably need to give some epi, that type of thing, epinephrine. So all but amoxicillin are absorbed on a better empty stomach if you're doing teaching. You can eat with amoxicillin. The amoxicillin is more commonly used form of penicillin. So she was saying, allegedly, this was Faye's note, that you might need to have another form of oral, another form of contraceptive. So cephalosporins. Any questions on penicillin? Just think penicillin anaphylaxis. You can think of like, my sister is allergic to amoxicillin. Oh, with amoxicillin, you can do that with milk. You can take it with food. Yeah, I think so.
Yeah.
That's a good question to look up. Does anybody know the answer on that one for?
Why not? Okay, to eat amoxicillin for all other cylinders on empty stomach.
Okay. But augmentin can cause it's not uncommon for that to cause some GI issues and like nausea. It's not an easy drug to tolerate. So I don't know I don't know if you can do milk with it or not. That like if you look it up, it'd be a good teaching. I don't know. But that's a really good question. That's one of those ones where I asked Dr. Google. I asked Google about it. I'm like, I wonder about that. Like ask the why question all the time. It'll help you look, because then once you ask that question, you'll know. And then you'll remember it, because you'll be like, oh, well, I know this about this drug now. And that'll help you know more about that drug because you have a folder. So yeah, good. Be curious. Yeah, be curious and ask questions and look it up. It's good. Absolutely. I encourage you to do that. Cephalosporins, these are going to have the prefix ceph or either with the PH or with an F. There are multiple generations of them as they come out. Most of them are broad spectrum. I'm not going to go into too much detail on them, but there's a lot of detail out there online on different cephalosporins, and what they treat and why they treat them. But to know that you'll give a lot of these are pretty safe and effective. I've, I don't give a whole lot of, given some meds as a nursing student, and I've given a lot of cephalosporins, different types. And sometimes they'll use them for surgery as a prophylaxis. Guess the term prophylaxis, it means like preventative. So an example of someone who might take prophylactic antibiotics would be someone who's had a heart valve surgery and they're going in for a dental procedure, like they're getting their teeth cleaned. They will put them on amoxicillin. Oh, wow.
Her face is like so smooth. But all year she's worked.
Oh my goodness. So yeah, big issues sometimes. Yeah, those prophylactic things. I have a valve disorder. I have a aortic valve regurg, and so it's bad valve. And so when I was a kid, they used to put me on 3 grams of amoxicillin every time I got my teeth cleaned. So I would take like, I don't know, it was like 6 pills on that day. I had to take a couple ahead of time and then take the other ones a couple hours after the first, and it was just to get my teeth cleaned. And like, if you think about that, you're like, did I really need them? Probably not. I'm still here, and then after a while, they're like, oh, that's probably not best practice considering antibiotic stewardship. So let's stop doing it. Guess what? 20 years later, I'm still here and haven't gotten some weird endocarditis infection. So think about all of those antibiotic resistant microbes I just helped to make in the world, right? Because of codeine. So like, just to think about like how often do we overuse these things? We don't need them, but sometimes we really need them. Um, so again, when it comes to cephalosporins, the most significant adverse reaction, but this one is going to be anaphylaxis. And there is some overlap between cephalosporins and penicillin. So if you might see a question that says, a nurse is looking at an order for this patient and they have an allergy to penicillins. Which of the following medications should they question? And they'll be like, a cephalosporin. And you're like, oh, okay. So you should probably go, hey, doc, do you still want to give them a cephalosporin considering they have a reaction to penicillin? And they'll probably like, yeah, let's just keep an eye on. But that'll be the NCLEX question will be like, they'll want you to know that there's a cross sensitivity to penicillins and to cephalosporin. So that may be a test question, and you may see that, but I've seen that as a sample question of that. Tetracyclines is the next one we'll take a look at real fast here. Tetracyclines were pretty common back when I was younger. They were really used more in the 50s and 60s and in the early 70s when I was like a young kid. And so there's a lot of anti-resistant bacterial strains for those. We can blame the boomers for screwing up things again. Go boomers. Thanks for doing that for everybody. It's bacteriostatic. It's a common treatment for acne today, these things, Lyme disease, H. pylori. But the most significant adverse reaction is, I think, toothless cycline as opposed to tetracycline. I think toothless cycline. That's the way I kind of remember it. And it stains your teeth brown. And it puts these little brown spots, these brown lines across the front of your teeth. And my wife has some light brown spots across the front of her teeth when they gave her mom tetracycline when she was in utero because, well, they did that back in the day. So it's amazing anybody who's a Gen Xer survived. Latchkey kids and, we were just being experimented on. So it's teratogenic on the fetus. What's that? Teratogenic. It's like birth conditions. Yeah, I think birth that.
But it's weird. Like in the uterus, she didn't have any teeth, and then she was born, and then later she got teeth, and she still has that tetracycline in her body.
Yeah.
That affected her.
Yeah, it's the calcium in the teeth when the teeth were developing. She was and they're crazy. Right? Or maybe they gave it to her when she was a kid too. I don't know. That's possible too. So it can cause discoloration of deciduous teeth. And then for her, she may have been a little older. But the whole point is pregnant women shouldn't take tetracycline in their last semester. And so yeah, and so she must have, it might have been when she was younger, they may have given it to her too. Like I said, it was back in the day, and there weren't a lot of options. So tetracyclines must be taken on an empty stomach. So this one you don't want to give with mouth. So and maybe amoxicillin you can. Amoxicillin you can, but I don't know about that. But so don't give these because these can affect the absorption. So that's a teaching point to know. I try to keep the teaching points to things that might be on your test, as opposed to, yeah. And so calcium ions bind to tetracycline and they block absorption. And the way to kind of think about that, think about, we know about the teeth, right? Teethless cycling, we can call it teethless cycling, teethless cycling. And it stains the teeth. So, and teeth, you can think calcium, right? Calcium, strong teeth, strong bones, right? Well, what's it doing? It binds with the calcium, and that's why you get the staining. So now you know you got the Y here. So what does it do? It's binding with the calcium and the iron. It blocks the absorption, but it also stains the teeth. So that's a way to kind of remember, not with milk, or anything like that. And not with your, worry about your teeth, worry about that type of thing with the kids. So with that, maybe that'll help a little bit. Macrolides, different type of example. These are like erythromycin, azithromycin. You might have gotten a Z-Pack. I get those periodically when I'll have a sinus infection. Azithromycin, erythromycin. They're broad-spectrum antibiotics. Super infections are likely, and because they're frequently prescribed if they have an allergy to penicillin. But they're also they're easy for a doctor to give. And they're like, all right, well, will you get out of my office if I give you a script for a Z-Pack? You're like, yeah. And the patient feels good, and maybe they need it and maybe they don't. But look at the suffix here is thromycin. It's not just myosin, but thromycin. You see how it's a little bit longer, thromycin. That'll become important when we look at aminoglycosides, which have myosin as a background, but they're pretty toxic antibiotics, but thromycin are not as bad. So I want you guys to see the difference there. So erythromycin versus myosin. Erythromycin should be taken with food. Azithromycin 1 hour before or 2 hours after a meal. And clarithromycin rarely causes GI side effects and may be taken. So I don't know how to remember that. That was just in the special notes on the bottom of her slide. And I thought, I don't know if she mentioned that and if that's important to her, but I better put it in your notes. Just so you see. Fluoroquinolones. The thing that you really need to know about these are going to be the suffix, which is fluoxetine. And so you got levofloxacin, ciprofloxacin, Levaquin is pretty common. Cipro is still often give Cipro. I've gotten script for Cipro when I've gone overseas to do mission work, and I might be in a place where antibiotics are not great and GI common or issues are common. And so they'll give me a script for Cipro to take with me in case I, get an infection or something like that. Usually just a couple of days to get me through till I can get home or get to some better medicine opportunities. But when I'm out in the bush country, sometimes it's nice to have. Don't take it, so it doesn't lead to antibiotic resistant bacteria, right? But sometimes it's nice to have. Fluoxetine, they're potent. They're mostly gram-negative. But since they're stronger, it's got a little sinus infection. You don't need that big gun. You just need to knock out the, amoxicillin or something like that. Often used for UTIs, so pyelonephritis. Pileo is an infection of, and nephritis is you guys know what nephritis is? Kidneys, yeah. So it's infection of the kidneys. Frequent resistant bacteria with those conditions. So you'll see them with skin, bone, genital infections because it's got good tissue penetration. It can really get into wherever that bacterial infection is because the antibiotic has to get to wherever the bacteria is in order to kill it. If that makes sense. There's part of the reasons why when people have bone infections or they're diabetics, it's so hard to treat them because they already have poor perfusion to their toes and so forth. And so blood's not getting there. Antibiotics that travel in the blood don't get there very well. There, and that's part of it. We'll type in. They can cause QT prolongation. I don't know if she'll ask about that. Probably not. But the QT prolongation that's in your heart rhythm strip. And so it's basically if you take too many medications that have a cumulative effect with QT prolongation, you can put someone into arrhythmia. That's just so it's sort of It's a nice to know about a drug if you're a prescriber or if you're a nurse. And so another drug that gives QT prolongation that you'll probably need to know down the road in like med surg too will be oh, blank. So not Zosyn. Odancitron, which is what's the trade name? You give it for nausea. What's the word we all think of for nausea?
Right.
Zofran, thank you. So see, yeah, so Zofran can cause QT prolongation as well. And so can like tyrosine or yeah, so we can like say this person was having a stomach ache and we gave them some Zofran along with because they were getting this medication, it was causing them to be nauseous. And so they're getting like Cipro, they're feeling nauseous. We give them some Zofran and that when and they're having a problem sleeping, so we give them some other medication to help them with sleeping, which can also lengthen their QT prolongation. You can see how we can start stacking those things up, and that's why it's helpful to know those stuff. You're like, oh, hey, did you realize that you might be doing this? So the most significant adverse reaction to know about fluoxetines is tendon rupture. That'll be the one you'll probably get asked about. And you say, oh, flock, just ruptured my tendon. Or fluoropumitlons can put you on the floor. So if you see flocks in there, you can think you have tendon rupture. Oh, flock, I just ruptured my tendon. I'll put you down there. So aminoglycosides, I think of them as aminoglycosides. They're amino antibiotics. So there's going to be gentamicin, tobamycin, neomycin, and you can see the mycin in here. See how it's different than the thrombolysis, which were earlier, right? So I think of it, mycin, my son, is aminoglycoside. He's just a little bastard. And they're pretty strong, and they have a mean effect on the kidneys and on the ears, primarily. They're narrow spectrum antibiotics. They can be used to treat gram-negative bacteria. They're more potent than other antibiotics, and they're like a serious gun. They're given primarily IM or IV because they're not absorbed well in the GI tract. It's probably a good thing, but they have a narrow therapeutic window, and this is the primary class that you'll do peaks and troughs on for antibiotics. And guess you remember peaks and troughs from earlier in the semester. So we give a medication, and so maybe an hour later it hits a peak, and then throughout the day, whatever the half-life is, it'll have this trough, and then at some point it'll reach the minimal threshold and it'll continue to go down. And we want to keep that drug level in the blood into this therapeutic window, if that makes sense, where it's high enough that it causes the effect we want, but low enough that we don't cause an unacceptable toxic level. And so these are one of those medications where we have to do the blood draws. So like lithium is another one, the digoxin's another one, but we'll see this with like gentamicin, tobamycin, and some of those other mycins. So what to know about them? Ototoxicity, that's basically the toxic to your ears. And that's when we get too much, basically at an excessive trough level rather than excessive peak levels. Oh, I didn't know that. This is from excessive trough levels. I guess it comes down. I don't know how that works. It was just in your notes. So that's a question I'll need to look up and look up. Dear Dr. Google, explain this to me. I don't know. But the first sign of ototoxicity is tinnitus. Do you guys know what that is? It's that ringing in your ears. And so if a patient starts complaining about ringing in their ears, they're like, yeah, my ears feel weird, or I'm hearing a high pitched squealing. You're like, do you normally do that? I mean, do you normally do that? Or is that new? And if it's not, then you might want to consider stopping the medication or reaching out to the provider or doing a little bit more, seeing what happens, what you need to do with that particular location. If it's too high, it would be like, okay, let's not give more furosemide. That's one that it's a diuretic that can cause tinnitus if you push it too fast. We'll probably get the aspirin today. And that's a cause of that. I try to wrap you guys up here in the next couple of minutes. So nephrotoxicity, the thing that most, just remember, aminoglycosides are amino things. They're amino antibiotics, and so think nephrotoxic. Think my son is aminoglycoside. He beat up the new kid. Me. So that helps. That might help you remember that one. So I'll just keep running through these a little bit quick here. Glycopeptide is vancomycin. That's that one. It treats hard to kill stuff like MRSA and C. diff in the oral form. The must know side effect is this one. She didn't mention this in your slides, but you might want to know some antibiotics. And that's vancomycin flushing syndrome, or it's called the red man syndrome or redneck syndrome. And that basically causes flushing from giving it too quickly. And so you want to stop the infusion and slow it down, or stop it, readjust your rate, check your rate, maybe need to give it slower, reach out to the provider. They might say, get some Benadryl or something like that. And do it. But that's one to know about. Vancomycin. It can cause, oops, I didn't finish that thought. It can cause phlebitis, which is where an extravasation. So it can cause injury to their site, your IV site. Sulfonamides, these are often used for UTIs, ear infections, and bronchitis. The main teaching on these are they cause sun sensitivity and Stevens-Johnson syndrome. And Stevens-Johnson syndrome is basically, it causes like blistering of the skin. And so if you think about how like sulfa drugs can cause a sunburn, think about Stevens-Johnson syndrome, but it's like a chemically blistering of the skin. So very similar to a sunburn, but it's just done chemically. It's a really horrific thing that can happen to kids. And it can be hard on the kidneys. So those are the things that take a look at those. Remember, so drink the teaching on that. I said drink water when taking med. And the reason why they're hard on the kidneys is it can cause kidney stones. So if they drink extra water, then that'll help flush the crystals that it can sometimes cause out of the kidneys. So that's the teaching on that one. You should probably know are these three here. And then this cross sensitivity. So if you guys are looking at your notes, you might want to make a note there. So if they have a sulfa cross sensitivity to like sulfonylurea medications, which is glyburide, which is in your it's anti-diabetic medication, and or a sulfa diuretic like a thiazide or furosemide. If they have you might just, that's another one of those cross sensitivities where they could have, if they're allergic to those, the sulfa drug might not be the best choice for them. I don't think they're super common anymore, so it's probably not as big of a deal, but you know. Other anti-infectives, metronidazole, it's a part antibiotic. We mentioned it a little bit here, but we got the azole here, part antibiotic, part anti-cortisol. So it treats C. diff, trichomonas, GIG, tract issues. Key teachings: avoid alcohol. It can be taken with food. It can darken your urine. But the thing to know is, again, C. diff, and you can think of, I take Flagyl or metronidazole for C. diff or diarrhea coming out of my azole, right? So that you can remember that one. Anti-tuberculosis drugs. This is, I don't know how deep she went in this. The thing that you probably need to know most on this is you have to take medication for a long time. And it's not like weeks, it's months to a year to treat an active TB infection. After, I think you'll learn more about it. So I don't know how deep she'll go into TB. Did she go into it very deep in it? Yeah. Okay, so I won't spend time on that. But isoniazid and rifampin are probably going to be the two you'll see the most. B6 helps with some of the side effects, and you can give isoniazid to pregnant women. They just need to be on B6 to help prevent side effects. Antivirals, I won't go too deep into these real fast, but she had some slides in there. The main thing on the drugs are right here. I'm trying to go quick because I got class in a couple minutes. So um, you can have beer in the name, so like a cyclovir or ribavirin. And so you see the fur in there. So if you see VIR in a medication, it's probably used as an antiviral. So just a side of the note there. And then, so here's some really good antibiotic reviews. And so I tried to hook you guys up with some stuff that I thought was pretty helpful. So I watched this one twice. This is going to making. If you want to look more about Vanco or Sulfa, these are some pretty good ones. Simple Nursing is a good one on Vanco and gentamicin. And most of these are pretty short. The Simple Nursing has pretty good reviews right here if you want like test questions as well on the immune system and rationales. If you think she'll take you there. I don't know I only saw her notes, so I don't know what she. If you really want to go deep, like down the road, these are some pretty interesting. They're short videos, but they're pretty interesting on how to learn, like know the different classes and coverage and mnemonics broad or not. So here's a good handout. This is what I would take a look at. I look at the red stuff. So glycopeptides like vancomycin, look at like red man syndrome. Tetracyclines, teeth and bone changes, and at the bone, the teeth stain, right? Beta lactams, that's going to be like your penicillins and your just on your men's anaphylaxis. So nitromysodols, that's going to be your flagell, metallic taste. Does that make sense? Kind of take a look at those. Tendon rupture here and quinlones. And here's pain management. And I didn't go really deep in this one. The main things that you'll need to know. On the NCLEX, this isn't true in real practice, but on the NCLEX, pain medications are always perfect. So if you give pain medication at Our Lady of the NCLEX hospital and it's not working, then something's wrong. So it could be compartment syndrome, it could be something else. But just when you're taking the NCLEX, if pain medications have been given and they're not effective, something else is wrong. In reality, who knows, right? They could be drug seeking, they could have a high tolerance, maybe we didn't, whatever. We want to avoid giving opioids of other CNS depressants. Start low and go slow, especially with opiate naive people, older people. And older and smaller patients might have lower tolerances in the receptors. So, and pain is always what the patient says it is in the NCLEX world. So if they say it's a 10 and they're still running around talking and you're chatting, it's still a 10. Even if a 10 was getting your face ripped off by a bear. So I'll let you guys take a look at these. If you think it'd be helpful for me to shoot a quick video on these, I can. It's not too deep, but I would take a look at I'd just review it quick. Take a look at the red stuff that's on here. Like aspirin can cause red man syndrome or Reye syndrome in children, so you don't want to give it to children, but you will give it for Kawasaki's disease. That's about the only time you give it because the risk-benefit ratio of giving aspirin is better than the side effects of Kawasaki's. So it can cause premature closure of the ductus arteriosus impetus, so it's contraindicated in the third trimester of pregnancy. Don't give it to a pregnant woman, it's their third trimester. Ketorolac, don't give it other NSAIDs. Tylenol is pretty safe. It's hepatotoxic. Anybody know what the antidote for Tylenol or acetaminophen is? Yeah, acetylcysteine. From Mucomyst. Know that one. You'll see it again as a test exam. So question. Know that. Learn it. Mucomyst. You should know Mucomyst from our respiratory section. It loosens, breaks up bronchial secretions. Local anesthetics are going to be like lidocaine, benzocaine, novocaine. You can go to the dentist, you get a filling, and they give you novocaine, right? The cane for the pain, it numbs things. There's a cool thing they can do, a Q pump, and they basically put a little thing of like lidocaine, and they just like put it in their into the joint area, and that way they don't have to give narcotics. They can just numb the area for a while. That's pretty cool. Muscle relaxants like baclofen. Let's quickly go here to, I'm just going to mention this one, cyclosporin or cyclosporin. I've seen this one around. I this is for this it suppresses the immune system, so it helps prevent organ rejection. And so I think stops the poor cyclosporin, starts the poor cycle of organ rejection. If that helps you remember cyclosporin, you can think of a cycle of a poor outcome of organ rejection, or however, because there's like other cyclo medications out there, and you'd be like, which one is it? What's it? If you think cyclosporin. Cytotoxic agents like methotrexate, and they use this things for like bone marrow suppression. It's contraindicated in pregnancy. They actually use this to dissolve fetuses in a pocket pregnancy situation. So it'll like go, oh, this is it supposed to be here, this tissue, and it'll dissolve it. It's an interesting way to medicate yourself the body get rid of it. So those are there. These are the ones that I would take a look at and review. This is a really good review of analgesics. These two here, and I've watched them a couple of times. They're pretty high yield and they're short. They're like 8-10 minutes, and so it's definitely worth your while. She can cover better than what I can cover in the time we have, and she does it better. She's got better graphics, and so go watch those. And then Simple Nursing has got another one on there. And you can Google Simple Nursing, and then like sometimes you'll have these sites like back up in the GI section where they have the video, and then there's a bunch of sample questions that you can go through and like video rationales on why they're right or wrong. They're really good. So here's some question reviews. I didn't put very many in here. So just real fast, a physician orders penicillin, and the nurse orders, administers drug is ordered, and the patient has an allergic reaction, and then she checks medication, or he checks medication, or she finds that the patient's allergic to penicillin. Whose fault is it? It's the nurse giving it. It's the pharmacist for filling the prescription, and it's the physicians for like giving them a medication that they're allergic to. But the nurse is also liable. It's one of those things that we need to know our drugs and to look and see if they have any allergies before we give a medication. There's that one. Rice syndrome is associated with the administration of what over-the-counter medication? Aspirin, right? Yeah. I'm gonna avoid that one. Okay. What's the before we move on, what is the antidote for this one? Acetylcysteine, right? Yeah. You go miss. Hey. Walter, teenage patient, because he ODs on Tylenol, which liver or lungs or kidneys or adrenal glands or brain, or I don't know. What do we need to worry about there? Liver, yeah. So I said that. But all right. So prolonged use can lead to renal dysfunction, but the primary concern is the liver. What do we need to worry about in terms of which pain med is hardest on the kidneys? That's all far as the over-the-counter stuff. Yeah, like ibuprofen and naproxen sodium and those NSAIDs. Those, yeah, very good. And the antibiotics that kill bacteria are which ones? Bacterial side, right? Yeah. Yeah. And what's bacteriostatic? Yeah, it doesn't let them grow. Exactly. An antibiotic should only be prescribed if this one. What's wrong with this one? Do we give it, that, right? Nothing with viruses. It doesn't help with viruses. Let's see. There's some good ones in there, chickies in it, but they like C the most. That's it. So you guys are welcome. Has this been helpful? Great. It was nice to meet you guys too. Yay. I made that. I would really like to look forward to seeing you all down there. I got accepted into the MSN in education program here. So I'll slow walk it, but maybe like a year and a half from now, I might be doing student teaching the way they do some of them. I'll continue on. Yeah. Yeah, I'm gonna go to work. It's just well, so that's probably more classes semester. I'm kind of burned out on school, but I've enjoyed teaching you guys. It's real fun.
Yeah, it's really great as a student. When you're a student, would you really?
If you guys need anyone before, if you guys get your exam on Thursday, like would be fine soon. This week's an interview session or whatever you guys. I want you guys to do well. I want you to get your A.
Yeah.
And,
I'm gonna get A's. I got it, I probably passed out in the class.
that would be awesome. Any way we can help them succeed. And that goes in, we got tutors for other topics too. We can help you out. So we can help you.